Hi, everyone. Welcome. My name is Eleftherios Soleas. I'm the Director of Lifelong Learning and Innovation at Queen's Health Sciences, as well as the Provost Special Advisor on Generative Artificial Intelligence. It's my joy today to welcome you to our second webinar in the AI in Healthcare series. Today, we're going to be having Dr. Joel Moktar present us today on diagnostic AI in clinical care. So folks might remember from the last session that we're going to save question and answers all the way to the end. But before we get on started with that, I'd like to begin by acknowledging that we gather that Queens is situated on the lands of the Anishinaabe and the Haudenosaunee peoples who have been guardians of this land now known as Kingston since time immemorial. On topics like AI, I like to think about things like environmental sustainability, indigenous data sovereignty, and how we are deploying AI, being thoughtful and seeing how that is contributing to our practice and advancement of truth and reconciliation, as well as justice for all people. So let's keep a mind on that for the rest of the session. This program does have some disclosures for folks to be able to see. So we've received in-kind support from each and every Ontario CPD office, as well as foundational funding from the Future Skills Centre. So our gratitude to our CPD office partners, as well as to the Future Skills Centre. So there are some disclosures from the Planning Committee, various direct financial relationships from various institutions where the Planning Committee are employed, as well as some funded grants in areas independent of artificial intelligence. So this program mitigates potential bias with all programs beginning with a needs assessment. And the planning committees are made up of all members of the healthcare community. There are no industry personnel on the planning committee. Presenters are required to disclose any and all relationships that they have with industry, and we ask for your feedback, which we'll be distributing to you with a post-program survey that is also how you generate your certificate. So without any further ado, I will pass it over to Dr. Joel Moktar. One moment, I've got your bio here, Joel. Joel is an orthopedic surgeon working at the Northern Ontario School of Medicine. He completed his medical degree, surgical training, and master's degree in Toronto. He's passionate about leading healthcare innovation and exploring new ways to improve access to specialist care for Ontario's patients. He is the founder and CEO of QuickChart, as well as he has a degree in medical engineering devices. So, Joel, without any further ado, I pass it on over to you. Thanks so much for being with us here today.
Thanks. Let me just share my screen. All right. Is that coming in okay there?
Looks great, Joel.
Okay, perfect. Okay, thanks for the intro and thanks for inviting me. I work here in Northern Ontario and one of the associate profs at NOSMU. And in disclosures, I do have a software company. This is an AI platform for clinicians and patients, no other financial disclosures. So today we're going to be talking about diagnostic AI in clinical care, understanding clinical decision support, and diagnostic AI. So at the end of the session, we'll be able to explain how these tools are developed, validated, and deployed in clinical workflows. We can learn how to appraise some of their claims and use performance metrics within the clinical context. And we can discuss AI use with patients and colleagues while addressing uncertainty, bias, and oversight. So AI is already here, and where are most of us encountering AI today in our clinical practice? Probably ambient scribes and maybe some of these clinical decision support systems, as well as evidence retrieval platforms. So we'll be talking about these three different things today. So a bit of a provoking statement to start. In 2024, when we started this journey and we started to use these AI tools, the message was AI should never be used to make a diagnosis or treatment recommendations. However, in the near future, I think that AI-assisted management may become the standard of care. Previous advancements in diagnostic medicine, from laboratory testing to CT scanning, were all initially criticized as expensive, unnecessary, or disruptive. Today, they are indispensable and in some cases, the standard of care. Not all AI is the same. There's different AI systems in our healthcare system that we can access. There's rules-based systems, for example, drug interaction software. There's evidence retrieval AI, such as open evidence. There's ambient scribing AI. There's a number of scribes out there, Heidi, QuickChart, Tally. And there's diagnostic AI tools as well. How good is AI at making medical diagnosis or treatment decisions? Well, when we look at the general trend of all AI models, at least those in the public realm, we can see the benchmark performance is drastically improving. And about a year ago is when most of these models crossed this benchmark, which is a AI performance on PhD level science questions. They crossed the expert human level last April. And now they've gone far beyond that. Most models are approaching 90 to 100% on this benchmark test here. So the models are getting quick and they're getting better very quickly. And it's really changing the way in which we can practice healthcare. But how good are they at actually making medical decisions? This is a study by my co-founder. He's a cardiologist in London. He looked at evaluating large language models in cardiovascular antithrombotic care. So this study put together a case bank of clinical scenarios and then tested a variety of physicians with different skill sets and training levels against some of the leading AI models at the time. So this was a tough question bank. This is how the clinicians scored. So senior residents scored about 48%, cardiologists 42%. Not surprising, these residents, they're studying for their exam. They're about to become staff docs, so they have the most knowledge. And then it tapers off with junior residents, medical students, general practice. When we compare this performance on this standardized question bank to AI models, here's the difference. So some of the most recent models at the time, again, most of these are now a year old, performed very well on these questions that were cardiology specific. My group here took this step further. So we looked at evaluating the performance of AI models in generating an assessment and treatment plan from orthopedic medical records. So this study has just been submitted, but what we did here is we said, well, it's great that AI can score well on the USMLE, or it can do really good on a question bank, but how can it do on actual charts, right? Medical records of patients. So de-identified patient records were truncated, and the actual diagnosis and the plan were removed from the note. And then we tested a few different AI models to see if they could come up with their own diagnosis and plan, and then had blinded expert reviewers rank the AI outputs. So we can see here some AI models, 99% accuracy in terms of diagnosis. So this agrees with the surgeon's diagnosis of that case, and 86% score on coming up with the same plan as the surgeon. So a lot of agreeability or non-inferiority of these models when compared to specialist consultants. This paper is from a year ago. This almost took this a step further, and they looked at an AI system that was optimized for medical dialogue. So they had 160 clinical scenarios with standardized patients either interfacing with a physician or interfacing with an AI chatbot that was trained on this specific task. And the SPs ranked the AI chatbot actually as having more perceived openness and honesty, generated more confidence and care, and actually more empathy. And this is interesting because we typically think, well, we're human, we're the ones that are going to be displaying empathy more. But, we've all been there at the end of a busy day, you're rushing to finish clinic, maybe you're up all night, maybe you got to rush home. Empathy is something that we can't always deliver. And according to this study, the AI chatbot was better at it. It was also better at actually diagnostic accuracy and a management plan, as well as escalation recommendations. So a little bit of a controversial study, but very interesting to see the speed at which this is developing. So in terms of looking at how these models actually work, there's been a lot of change in the last few years on how AI models actually work. So we can think of the 2024 models as almost like a medical student recalling a case. So you'll ask it a question, it will answer with its own internal training, and will do a pretty good job. But the models of today are very different. So models today think more like consultants in that they typically start with a retrieval-generated augmented search. So they search the internet, they search PubMed, they search for all the recent data and literature. They then combine that with their own internal thinking and a reasoning layer on top of this. So more closer to a consultant reviewing the recent literature, processing it, and applying the relevant portions to the case and the patient in front of them. So where will most of us encounter AI in our practice? Typically, ambient scribes is probably the front door to AI in most of our practice. I think many of us are probably using these tools. Many of these ambient scribes now have clinical decision support or evidence platforms built within them. There's Heidi Evidence, there's Quick Chart Intelligence, there's Tally Clinical Decision Support. And the other place is through evidence retrievals. So these are UpToDate now has an AI chatbot built in, and Open Evidence is the other one. So Open Evidence is a very popular platform. It's really changed the way in which many physicians practice medicine. And essentially, it's like a smart search engine with a chatbot functionality that is trained on several leading journals. So the way it works is you can ask it a clinical question. You shouldn't enter PHI into this, but you can ask it a clinical question and it will do its best to answer that based on the evidence. And the reason why this became so popular is because it gives you the papers and gives you the resources where it's drawing these answers from. So you can see here, this is a question: how do I manage AVN of the shoulder? Here's a workup. Here's non-operative management. Here are some recent studies. So this provides evidence-based answers and cites its sources. It's designed to assist with diagnosis, treatment, and review of the evidence. This tool has become very popular. Approximately 40% of all US physicians are using it, with millions of clinical questions generated each month. And it's one of the fastest growing AI tools ever adopted. However, there's limited independent validation. There's hardly any evidence to say, is this actually correct? Is it actually providing the right references? Hallucinations, which are where an AI basically makes something up, are a risk, but in general, hallucination risk is decreasing with time and is much rarer today than it was a few years ago. There's limited transparency regarding model performance and benchmarking, and there's some concerns about targeted advertising within these tools. So this is what's coming, and this is a Viewpoint editorial that was published recently looking at some risks of advertising within AI. Because clinicians are using this tool so frequently, ads can now be targeted to specific clinical decisions at the point of care. And we need to protect clinical integrity. There should be a separation between AI-generated clinical content and the ad itself. The ad should clearly be labeled and should not influence decisions, but this is the concern. And there's a call for oversight and transparency with these tools, is that clinicians should understand that commercial content may be incorporated, and there should be a clear disclaimer of where it's incorporated, and there should be options for ad-free subscriptions as well. So that's the evidence retrieval platform, Open Evidence. But the other place you might encounter clinical decision-making is within ambient scribes. So ambient scribes, as many of you probably know, capture a dialogue between the patient and the clinician and then generate a medical report. That's kind of the first step of this technology. And now many of these platforms have built evidence platforms within them. So at the point of care, you can then ask a question within your scribe rather than having to go to Open Evidence or UpToDate. So this is just a demo video showing how one of the platforms works. So this is a case of a 39-year-old male with a large rotator cuff. This is a test or a synthetic patient. And this is something in shoulder world that we often struggle with, right? The young patient with a massive tear. So I'm asking Quick Chart Intelligence here, is BioBrace a good option for him? So what this does is it takes the patient's demographics, it takes the physician's geography, because there's some local guidelines sometimes you have to be aware of, and it does an evidence-based search based on these factors, and then can point the clinician in the direction of the recent literature. So it's like having almost like an evidence-based co-pilot embedded in each encounter. It doesn't make the recommendation for you, but it says, hey, here's some evidence, here's what these papers have said. You can actually click on the resource that it gives you, and it takes you to the website so that you can review the American Academy's evidence-based guidelines for rotator cuff. So it's a pretty powerful tool that you can embed in your daily workflow. However, the strongest case for AI actually improving diagnosis today, or at least the best studied, are not in large language models, but they're in image-based tasks. So this is more of a niche subspecialty. Maybe if you're a gastroenterologist or radiologist, you have used these tools, but it's certainly more of a narrow scope, but with really good evidence behind it. So one example is AI-assisted polyp detection during colonoscopies. So it functions almost like a second set of eyes for the gastroenterologist or general surgeon doing the endoscopy. It highlights areas of clinical concern and allows the physician to have a closer look. Recently was published a meta-analysis of 28 trials looking at a 20% increase in adenoma detection rate and a 55% reduction in miss rate. So you can see here that it definitely improves the physician's ability to hone in and find these lesions. It didn't really change the time of the overall case, but did improve this tool. Another area where AI can help with diagnosis is during mammography screening. So this trial was published recently looking at a large number of women undergoing screening tests where an AI model actually triaged cases that may require more urgent radiology review and found that there was a reduction in progression because these patients were triaged a little bit more urgency. The same can be said for diabetic retinopathy screening. So this is another study. This one's a few years old, but I guess they were fresh out of the gate with AI tools. They looked at diagnosing diabetic retinopathy directly from retinal photographs with about 900 patients, and it's fairly sensitive and specific for early diagnosis and was one of the first FDA authorized tools for autonomous detection. And lastly, there's AI stroke and hemorrhage detection. So this identifies and flags certain areas on a brain CT for a more urgent radiology review. And a recent study showed that it reduced the turnaround time to reporting and completing the scans down to about 73 minutes with a fairly high accuracy and sensitivity. So these tools, like I said, are fairly niche and subspecialized, but that's where they perform the best. I think for most of us, we can understand that we may not use these tools. We may be using the clinical decision support or the ambient scribe tools more frequently. But regardless, it's important to have a framework for how we can evaluate and critique the AI tools. And there's a number of different frameworks that have been published. These are a little academic, but there's STARD AI, which focuses on the accuracy, sensitivity, specificity. Decide AI. Does the AI actually work in clinical practice? It looks at the usability, adoption, and safety. Consort AI. Does the AI actually improve clinical care? And then Spirit AI is, was the AI study designed properly? So almost a critique of the literature. However, for most of us, we want something that's actually practical and a quick check mark. And this is a reasonable framework, I think, when you're looking at these tools. First question is, what is it actually doing? Are you making diagnostic decisions, or is it simply helping look at the evidence? The second is, where does the information come from? And this allows us to look for bias because we want to see, well, where's the study published? What kind of journal was it published in? Is it from the literature, or is the source unknown or vague? Can I verify the answer? Again, does it give references or explain its reasoning? And what happens if it's wrong, right? Is the error significant here? Can it harm a patient? Maybe I should be more cautious with this tool versus one where the error causes an inconvenience or much less risk. And does this actually make me better? Does this make me a better clinician? I think this is probably the most important question. If we use it as a tool to make ourselves better clinicians, then I think it's worth trying. So in summary, for that portion, do I know where it gets its information? Can I verify the answer and its reasoning? And what are the clinical consequences of that answer? So there's a lot of considerations with AI. It's a new technology. It's changing the world very quickly. I think in healthcare, I think it's okay to discuss AI openly. It's important to be transparent with patients, especially if we're using AI for ambient scribing. Consent is required. I think it's okay to discuss that with them using AI for clinical search, looking at the research. That creates a culture of responsible AI use rather than blanket rejection or blind trust. And we know patients are using AI. They're coming to our clinics with ChatGPT at their side. So we need to understand how this technology works. We also have to recognize that AI, they're not always facts, they are suggestions. We have to be able to still do our own research and verify the recommendations against the evidence and within the patient's context. Bias is an issue in AI. AI may perform differently across different populations, regions, languages, and different healthcare settings. It often depends on what data the AI was trained on, and if that matches your own patient population. And it's important to cross-reference the outputs that are inconsistent with your own clinical judgment. And human oversight is important, right? AI can be a useful tool, but it's not the final authority. And we should apply the same critical thinking we do when we get a consultant recommendation or a referral from another colleague. So trust but verify, use AI transparently, recognize its limitation, and keep human clinical judgment at the center of care. So what do humans still do better than AI? A lot. Our advantages is our clinical intuition. AI is good at assessing data and retrieving documentation, but we understand a pattern. When we look at a patient, when they walk into our room, sometimes okay, something's off. Our own lived experiences, right? The years of cases, those nights on call as a trainee, complications, judgments calls, lessons from colleagues have shaped our clinical judgment. And that's something that can't be replaced by AI. Physical examination and touch is important in healthcare. The bedside presence. These are things that patients need when they're sick. And I think this is something that we can really bring, the art of medicine and the healing art of medicine. And also the personal context, knowing the patient's family, their fears, their work, their culture, their finances and supports. All of these things an AI chatbot or an AI agent won't have access to. That's what gives us our ability to really understand our patients and trust and accountability. Patients trust a human being. They want us there to help explain, decide, and reassure. So AI can help generate the differential, but we understand the patient behind that differential. Language matters. So this is something that's come up recently, and we're healthcare. We're not healthcare providers. We're physicians, right? We're healers, and that's really important because the term provider is a bit problematic. Provider reduces medicine to access and transactions. There's insurance providers, and now there's talk about healthcare providers, but we should really take back the word physician. Because we're not just carriers of their care. We interpret, we examine, we judge, we comfort, and we take responsibility. And liability, which all of us carry, is not just risk. It's actually a professional privilege. So liability sits with clinical judgment, diagnosis, consent, follow-up. AI and software can assist, but AI does not carry any medical liability and does not carry the moral or legal burden of care. I think if we accept liability, it means that society trusts us with high-stake decisions, and that the responsibility is what separates us from a tool, software, AI technician, or any provider. So I think we should be proud of this burden of liability. It reflects the depth and seriousness of our profession, and it's the price of clinical authority and the proof that our judgment matters more so than an AI agent. Thank you. That's the end of this, but I'm happy to take any questions.
Thanks, Joel. Appreciate it. To folks in the audience, you can use that question and answer charm down at the bottom of your screen. You can type in your questions there. Folks are also welcome if they'd like to use the chat, they could, but I think the question and answer charm will be easier. While folks are getting their questions on in there, Joel, I have one for you if that's okay.
Yeah.
So talk to me about like what does a typical like use of an AI for you in the case of diagnostic care look like? Like what's going through your mind as you make up a decision on which one you're going to use or why you would use one?
So, I think it kind of depends on the context, but and usually for me, it's like that tough case that there's no clear data on there. And, the example I gave is, young patient, large rotator cuff, a lot of fatty infiltrate. I think open evidence is a good tool for that. But it's more so to point me in the direction of the literature and to use it like a smart PubMed search or smart search engine more so than, you should do this for the patient and shouldn't do that. It's more so, hey, here's a bunch of literature, you can look at to help make the decision.
Have you had a chance to do any of to read a little bit more any of those cases? You said like, for example, the intracranial bleed or any of those. Did you get a chance to read about those particular uses?
Yeah, I mean, other than the studies, I know that they are, they've been shown to be quite good at diagnosis, but again, it's not applicable to, I think, most people here. I would assume it's like very niche. It's rolled out in a few U.S. centers. It's not commonplace yet. I don't think it's anything any of us will encounter. I mean, if anyone has encountered these, I'd be curious to hear what feedback has been. But I think most of us are going to be using these tools that we discussed: ambient scribes, clinical decision support, things like UpToDate and open evidence AI searching.
So, folks, I'm all set for those that have questions. If you want to type those on in the question and answer function, you can go ahead and do that. If you're having any trouble doing that, you can always raise your hand, and I think we can unmute you that way if you'd like. Go ahead, Deep.
Yes, thank you for the presentation. For the surgical setting, what the experience in using AI in surgery during the operation?
There are some tools now that assist in laparoscopic surgery, and there's a surgeon at UHN that presented on this recently at the general surgery meeting. It's similar to the colonoscopy example where the screen actually displays areas of concern in an area that you can zoom in on if you're doing a cholecystectomy or another laparoscopic procedure. So it's almost like image-based assistance. In orthopedics, we've got robotics. So we do robotic hip and knee replacements, robotic shoulder replacements are coming. The AI assists it with the templating or planning software, which is like three-dimensional software, and it can start with suggesting where your implants may go. But as far as actual intraoperative co-pilot or guidance, as far as I know, in ortho, I haven't encountered that.
So we've got some questions now in the Q&A section. So a couple of these, I think people are looking for your perspectives and opinion on rather than any specific medical legal advice. Okay, so I'll
Sure.
frame that here first. So if you're looking for medical legal advice, this is not the forum for it. If you're looking for ideas and perspectives, this is the right spot for it, and you should consider it within the scope of your practice. So a question with a bit of preamble. So like self-driving cars, will the limitation to full automation ultimately be who is responsible and who is liable, in your view? What do you think?
Yes. Yeah, I think so. And that's why I talked a lot about liability at the end, because, we kind of, it causes stress in our lives, obviously, to have to deal with liability. But I think having the liability is what gives us the authority and puts us in that position of power, which we should use with care. I think that it's, very unlikely there's going to be autonomous surgery happening anytime soon, despite what Elon Musk says. I think the trust from patients, similar to flying a plane, there's co-pilot features on an airplane, but you want to see those pilots sitting in the front of the plane and be reassured that they're doing the work. Pilots can make errors, surgeons can make errors. You want a good co-pilot sitting beside them. But I think it's going to be a long time before anyone gives up full trust to autonomous surgical devices.
All right. Thanks, Joel. What are your thoughts on involving patients in the diagnostic workflow that is AI enabled? Are there certain issues that you could see when we move to consider certain self-serve models?
Yeah, I think that's a really good question. That's what we're going to be seeing, and I see this in my own practice. And I'll just give you an example. I had a patient come to me who had uploaded the radiology reports to ChatGPT, and they were devastated because they thought they needed a wrist fusion. And I looked at the radiology report, and I disagreed with the radiology report. It was not pancarpal arthritis. I think the radiolunate joint was preserved, and I thought I could offer the patient a different surgery than ChatGPT had recommended him. So I had to spend a lot of time talking to the patient and highlighting the fact that the data that you put into these models is very contextualized and maybe not accurate, or maybe there's varying opinions, and you can be led down rabbit holes without having the full clinical picture. Like a physical exam is very important, history is very important. Patients don't know how to take their own history really, or physical exam. And so the self-serve models, I think, are useful in certain contexts, like, maybe it's the middle of the night and you wonder, like, what's this rash on my toddler? Like, there can be some value there, but still, I don't think it replaces clinical judgment, and it can kind of really lead you down a bit of a rabbit hole. So, we're gonna have to figure out in healthcare how we can defend against, all of these requests. People were Googling things a few years ago, and now they're ChatGPTing things. They're sitting in our office with 26 questions generated by ChatGPT, and that's certainly filling up public healthcare time. Time might be saved with ambient scribes, but then patients are coming with these tools. So that's something we're working on. I mean, I don't want to plug my own products here too much, but we want to build tools for patients that allows them to take charge of their health, to remember what the doctor said, and then to also ask questions that are reasonable in a Canadian healthcare system, that are in line with choosing wisely guidelines, for example. There's certain things that patients, I think, should be empowered to ask, and then there's things that maybe are not relevant to their care.
Thanks, Joel. We've got ourselves quite a few questions. Goodness, thanks everyone. Looking forward to this. So, what's your position on AI scribe deployment practices that do not involve a discussion with the patient?
That's an interesting one. So, CPSO, CMPA, the guidelines are you have to obtain consent to use the scribe. And that's what I do, and that's what we tell our colleagues to do in practice. However, I think that the point of obtaining consent is really twofold, and one is you're recording the patient, and the second is an AI model is sort of spitting out the refer or the consultant letter. But I'm not a legal expert, but I have a hard time justifying, in the future, are we going to have to ask patients every time we use an AI tool? Today it's ambient scribes. In the future, it might be, evidence retrieval. If the audio is not being stored anywhere, right? You're not recording video, you're not recording audio. That piece of it, I don't know why we need to obtain consent for. And we don't obtain consent to use an EMR. We don't ask consent to use a digital stethoscope. And a lot of these tools are now having AI embedded within them. So at some point, when it becomes solidified and when it becomes everywhere, we may not be asking consent anymore. I don't know if there's any older clinicians here, but when EMRs came out, I don't know, was there a recommendation to ask patients consent to store your data digitally on the cloud? That's essentially what these AI scribes are doing. And I don't think that discussion was really ever there. So yes, consent is important, but I don't know if it's going to be required forever. And I also think the other problem is, although we are required to consent patients for the use of AI scribes, we can't fully, and many of us can't fully explain how the technology works. So I don't know, how good of a job we're doing of consenting patients.
Have you found a difference in the way that physicians may diagnose compared to AI? What was commonly found to be more correct in the times that we actually do heads-up comparisons?
Yeah, so I mean, I think the interesting thing is that we all have bias as physicians, right? Maybe we call it experience, or maybe we call it bias. Um, and like I've looked at this, and I think that AI, like on paper, objectively, does a pretty good job of diagnosis if you give it the right answer, but it doesn't have that weight of experience. And whether that's good or bad, it's hard to know. So, I may have had a complication a few years ago, a certain type of patient had a problem, and now that's my bias and I carry it forward. Some might say that's my experience. So I think that's important. I think by nature, we all carry some bias, but that's what makes us good clinicians, and that's what gives us judgment. So, yeah, I mean, that's a tough question. I think you kind of want to do both, right? You want to use your own experience and look at the patient in front of you, but also use an AI tool to maybe help pull up papers relevant to that case. And then you have a more nuanced discussion. But I don't think there's a clear answer right now at, which is better. But I think our experience really does make a huge difference.
A bit more specific of a question here. In your experience, is AI helpful in explaining or solving idiopathic diagnoses?
Yes, for sure. Um, I think if you give it as much data as you can within the context of that patient, I think it does. I mean, in orthopedics, there's maybe not as many idiopathic diagnoses, but um, it can be useful. It can also help you, formulate your thinking a little bit. It can help formulate the plan. I do find it useful, but again, it's not something I see a whole lot in my practice.
Uh, Still got about 7 questions, which is good. So, folks, we're gonna get through all the questions that we've got now. I can't guarantee any of the questions that come in after now, but we'll do what we can with the time that we still have. And Joel, thank you for being so giving of your time.
Oh, this is great.
Um,
Thanks.
in terms of AI image analyses tools, how do you suggest those be used? In tough cases only, or do you think people might consider adopting them in general? How do we prevent physicians from over relying on these tools?
Yeah, I mean, I think that kind of like I said, like they're fairly niche right now. What I foresee in the future is radiologists or groups of radiologists may have access to these tools and assist with, their report generation or triaging urgent cases. I don't really think anyone should be uploading an X-ray to ChatGPT and saying what's wrong here. I mean, it does a decent job actually, but there's no liability there, and it may miss things. So there aren't really commonplace image diagnostic tools available to the broader body of physicians that I'm aware of. That would require a Health Canada pathway as well, because if software is actually making those level of diagnosis or like ECG tools, then it generally requires a medical device classification. So I would say, you can use it for interest or research if you're going to be using something like ChatGPT, but it really rely on your radiologist or whoever's reading your images at this point in time, and let them try those tools.
A question that I can field that's in here. So, is there any research showing the percentage of Canadians that accept using AI in recording the conversation? Joel, if you have info on this one, you're welcome to do it, but I've got a relevant study that I can share with folks if you'd
Sure.
like.
Yeah. I mean, I know the OMD, or Ontario Medical Association, had a study on this, and the patient perception was fairly high. I don't remember the exact 80 to 90%. Other studies have shown that patients perceive more time with their physician because they're making eye contact, they're discussing things with the patient. So yeah, I think in generally it's viewed favorably. I think that ambient scribes, the outputs should be reviewed by the physician as well, obviously. But I think it's generally viewed upon patients favorably, as long as they understand, like, look, we're not capturing the audio recording, we're not storing it anywhere. It's merely a tool used to help me synthesize my plan.
All right. Yeah, that's definitely fitting with what I've been seeing out of the American literature as well. So in this case, it's a JAMA Network Open study from July of 2025. So it was 18 clinicians and 103 patients in the primary sample. 81.6% were comfortable with AI being deployed as an ambient scribe when they were told that it was being used. 55.3% were comfortable after they explained how the ambient scribe worked and where stuff was. So the more information that we tend to share with people and the more specific we get, the more it tends to be illuminating that informed consent has to be based on quite a bit more information than we may have initially thought. So a great question. Joel, question for you on to what extent AI might be used for research, scholarly writing, and evidence finding, so contributing to a decline in human expertise? And do you think that this could affect the integrity of future AI use?
Yeah, I mean, I sort of like, it depends on how you use the tool, but if you're kind of running ChatGPT for everything, you start to lose some of that critical thinking ability. Um, so I think it's important on how you use it, and if you use it like almost like an assistant that can help you find and retrieve data, I think it can make you more efficient. I think it can make you a better researcher. I mean, I use it when doing my research. Like it's very good at certain things, and other things it struggles with a bit. I think creativity. AI models struggle with human creativity, sort of designing things from a start. They're not as good at, and that's something we should be focusing on. But things like pulling up references or formatting the paper in a certain way, they are very good at. So it depends on what you're using it for. But as a research tool itself, like it is very good at analyzing large amounts of data, extracting data. We've built in our software a study screener tool as an example. So you can upload a study with inclusion exclusion criteria and quickly screen each patient at the point of care of whether or not they're eligible for a study. Some groups might be running 10 studies, and trying to remember who's eligible for what study is just hard to do. So in those cases, I think it is very useful.
I'm reading all the way through this particular question just to make sure I understood it. So, for hard to diagnose disorders, for instance, some autoimmune ones, do you think that AI could be something that could lead the talk and help individuals actually get a diagnosis when they've been turned away in other circumstances?
Yeah, I think so. I think there's less evidence on that, but there's like anecdotal stories, you may have seen in the news and so on, of someone who had a diagnosis. They went to a bunch of different physicians. No one could figure it out. They spent a long time uploading everything into AI and having a conversation back and forth with AI, and it eventually led them to a diagnosis that that was then confirmed by the healthcare system. So yeah, I think in those niche cases, it can help. I think the difference with that is you have to spend a lot of time almost interrogating the AI model, like having a back and forth conversation rather than just asking a single question. And the longer you have that back and forth exchange, the more accurate it can be with its final diagnosis. There was another article that came out recently, was can AI say I don't know? And if an AI model can say I don't know, then it's actually a sign of a pretty good system. So that's something we're looking at, because you might ask a world expert consultant regarding a tough case, and they may not have the answer either. So I think that's something we're going to see a little bit more of. There's sort of some publications on these niche cases.
Question of theory. It's interesting that patients sometimes find AI tools more empathetic to other human beings. Is this, as you suggest, mainly due to fatigue at the end of the day, or do human beings every now and then have something to learn from AI on being empathetic?
Yeah, that's a really good question. Like I sort of did an experiment with, it's not fully empathy, but like I looked at my triage wait list, and I had one of our AI models try and triage all my patients, and it tries to triage everyone with the most urgency, because it sort of perceives that resources aren't as limited as they actually are in real life. And if we think of empathy as a resource, like we run low on that resource sometimes as humans, and AI doesn't perceive those sort of things. So yeah, I think there is something to be learned. I think that study there was shocking to a lot of people. I think typically we thought, but we have empathy and machines don't. Turns out that they can display a form of empathy sometimes better than we can. But like I said, I think with empathy also should come experience, judgment, and understanding the patient, and AI is not quite there yet. I think if we free up more of our time throughout the day, we may have more empathy. And that's, the goal with AI, at least in my view, should be to give us our time back and make us more present clinicians.
Thanks, Joel. Question from a medical educator. So, how would you teach busy residents about the benefits and limitation of using AI in their clinical work, especially when the use of it went on, especially the use of it when on call and encountering unfamiliar issues?
Yeah, I mean, I think I would say that, if they prepare, and I'm okay with them using AI tools by the time they've practiced, I think it's going to be everywhere. So trying to hide trainees from AI, I think it is a mistake. That being said, they should still develop the critical thinking skills that are important. And I would almost treat it like an AI, let's say you're going to use open evidence as a trainee, or one of these other CDS tools. Treat it like you're attending staff, right? Present the case with all the details. Pretend like it's your staff that you're presenting to, and there's a little bit of that like fear, like I gotta make sure that this is accurate, and I've done a physical, I've done a history. I haven't looked into this, but I'm sure there's specific AI tools for building case presentation and helping trainees kind of build that back and forth ability. But if they treat an AI tool like a consultant staff that they're going to present to, I think it's a reasonable place to start. And then the last thing is to make sure that they go to those original resources and look up the papers, actually read the study where the AI model got its resource from, so that you're learning how to trace evidence back to its primary source, not just going for the raw output.
You're getting some compliments here, Joel, and I'm going to read one of them out loud. Excellent presentation and quite refreshing. As a patient partner active in research and healthcare initiatives with particular interest in AI, I wonder how you feel about partnering with patients around development and deployment of AI tools and guidelines going forward.
I think that's very important, and I think the patient's voice matters. And like I myself, I'm a patient, and like I've been through the healthcare system. And yeah, I think that we need to get all the stakeholders involved, and patients are the people that we take care of every day. So for sure, if there's patients that are interested and willing to participate, I'm happy to have that conversation with them, and I think all of us should.
Last two questions. What structures do you think need to be in place to ensure AI tools remain trustworthy? So evidence-based, not guided by funding interests or advertisements.
Yeah, I mean, there's definitely a gap here because the technology is moving so quickly that the law is way behind. There's various bills and stuff that are coming, but I almost think that we need to have like a benchmarking, or almost like a licensing exam for AI. And there's conversations around that happening now, because AI models are not static and they're not deterministic. They evolve with time. They may improve, maybe degrade over time. So we almost need to build a framework in Canada for ongoing, let's say, licensing or ongoing standard of AI models, that every year or so the vendor has to show that their model is meeting this gold standard. There's similar standards for, let's say, cybersecurity and tech infrastructure, but there's nothing for actual like clinical decision support, ambient scribing. That's something we're actually looking at.
And our last question, what are your thoughts on how to prepare our next generation of clinicians in the art and science of diagnostics in the emerging world of AI? Do we need to focus more on clinical reasoning and focus on integrating AI tools in the diagnostic processes?
Yeah, that's a good question. I think the physical exam and clinical intuition are going to remain very important. I think that just seeing that patient walk in the room and understanding what they look like, what they're there for, and that's something that I think human judgment is going to really value. And a physical exam, I think physical exam, especially in MSK orthopedics, is very important. A lot of people kind of rush to the imaging, but a physical exam matters a lot, and that's something that AI can't replace. I think it's going to automate certain parts like evidence lookup, pulling up the papers that matter. For those of us who have been around a bit, like the PubMed mesh searching, like that's going away, thank God. And now AI can really help with that. So I think focusing on those things that, like, it's almost like you take a step back, like what made someone a good clinician, 20, 30, 40 years ago, those skills are going to become extra important. And some of the ability to understand imaging or maybe reports are going to become less important.
Thanks, Joel. I did want to draw a bit of distinction between what it's like to use an EMR and what an A and the degree of bias that an AI could infiltrate compared to that. So I suppose if errors are made when you type into an EMR, or if you use stigmatizing language or something like that, an EMR could certainly perpetrate a certain amount of bias, but an AI is a bit more of a wild card because of the black box. I wonder if you think that the two are truly comparable in terms of the risk for information and privacy that they could have.
Yeah, not necessarily, at least not this time. I think you're going to see the two solutions merge into one, um, because an EMR is like an analog filing cabinet, and if you want to retrieve information on your patient, you have to access the filing cabinet and look for information. Whereas an AI system almost acts like a translator of information for you. Um, I think if there are certain benchmarks with clinician oversight, the risk of bias is reduced. But I've seen it. Someone copies an incorrect diagnosis from one chart in a traditional EMR, then that incorrect diagnosis propagates through the chart for eternity. With an AI model integrated into the EMR, it can. This is something we're building actually. It can cross-reference all the data quickly, and if a bias or an error or something came up at some point, you can then flag those issues. So I think of AI more like a very deep search engine, rather than something sort of, making the actual document or diagnosis by itself.
Thanks, Joel. So, for folks to note, the post-program survey for folks is in the chat. You can go ahead and give that a click. We're also going to be emailing that out for folks to be able to complete. Completing that post-program survey is included in your learning hours for today's webinar, and it is part of how we continue to do quality improvement for series like this, as well as our other CPD offerings. It's also how you'll generate your CPD certificate, those last two questions at the end. So, Joel, thank you so much for making the time and joining us today. For our audience, thank you so much for choosing to learn with the Ontario CPD offices. Letting you know that there are two more sessions in this AI webinar series free of charge, all being held from 12 to 1 p.m. The next one is actually next week on June 15th, and it's going to be on AI in care and therapeutics. So Dr. David Wilger and Dr. Mohammed Madani are going to be joining us from the University Health Network and from U of T to be discussing AI in care and therapeutics. And then on the 25th, we are going to be having Dr. Chandra Chandrasena, as well as Dr. Eric Wolterton of the University of Ottawa and the CMPA, our CMA, are going to be joining us for Administrative AI in Practice, Scribes, Scheduling, and Referrals. If you're not registered for those, you can go ahead and register for those at the same link you registered for this one. So my gratitude to everyone, and thanks so much, Joel, for making your time for this today.
Thanks, everyone.
Cheers. Thanks, everyone. I hope you have a wonderful afternoon.